opioid epidemic within the pandemic. We have an excellent panel who will be introduced shortly, which you see in front of you. But I just want to take a minute just to go over how this is going to go. So all the participants are going to do their presentation, and everybody in the back end, if you have any questions at the end of their presentation, please use the chat function or the question and answer function. For those of you who called on a phone, you could always send an email to johanna@middlesexchamber.com. That's JOHANNA at middlesexchamber.com. Once the panel is concluded, I will take your questions and answers and present them at that time. Again, thank you for joining us. And without further ado, I'd like to introduce our president, Larry McHugh, who will lead this discussion. Thank you.
Thank you very much, Johanna, and thank you very much to our great panelists here with us today, Kevin Elak, Dr. Kalinowski, Dr. Gianni, Dr. Allen, and Margaret O'Hagan Lynch. We got great panelists for this very, very important workshop we're running today. I'll introduce Tony Salvatore, the chair of MCSAC, in a second. Just a heads up to everyone, at noon today, we have another terrific function on our chamber luncheon with Tom Katsouleas, the president of the University of Connecticut, and that will be also on Zoom at noon. If anybody would like to sign up for that, they can. Again, we had 87, I think, just signed up recently. This event will have well over 100. It's going on Facebook Live. CTN, I want to thank them for covering it. We also have other electronic media on this and print media. And of course, it's on Zoom. So thank you very much to our panelists. Thank you much to Charles Mitchell, who's just done a fantastic job running our substance abuse programs here at the Chamber. And it gives me a tremendous honor to introduce Tony Salvatore, a former police chief in the town of Cromwell, town manager of the town of Cromwell, a long time supporter of both the Chamber and MCSAC, and a very close friend. Tony Salvatore, thank you.
Thanks, Larry. Good morning, everyone. It's a pleasure and an honor to be here with you and able to put on this important workshop. I want to take the opportunity to thank Larry and the Chamber for the unique relationship that MCSAC has with the Chamber. I want to thank the MCSAC team, and I want to thank our panelists for being here this morning to put this workshop on. Now it's my pleasure to introduce Charles Mitchell, who has jumped right into taking over MCSAC as far as being the point person. He did an outstanding job with this workshop, and it's my pleasure. Good morning, Charles. Take over, please.
Good morning, everyone. Thank you, Anthony, and I appreciate it. And, you know, once again, I'd just like to thank all of our distinguished panelists for coming on board. And this is a workshop that is really very near and dear to my heart, as well as I am 14 years in recovery myself and was addicted to opioids at one time in my own life. And I understand the necessity of having these kind of workshops to make people aware of it. I am also the Recovery Employment Program coordinator here at the Middlesex Chamber, which I help people who are in recovery from the opioid addictions, and I help them find employment, you know, through the efforts of meeting with other companies and agencies and getting everyone well connected. And I just want to thank Larry this morning for the opportunity of giving me this opportunity to work for the Chamber. It's been great. All my co-workers here at the Chamber who helped get things off the ground and continues to work with me, you know, without question. And again, as we go, I would like to just introduce the panel: Kevin Elak from the Middletown Health Department, Dr. Michael Kalinowski from the Durham Middlefield Wellness Coalition, also Dr. Hamilton Gayani from Adult and Addiction Psychiatry, Dr. Allen, the medical doctor, Hartford Healthcare, and Margaret O'Hagan Lynch for Demas and Connecticut Valley Hospital. And with that, we're going to start off the panel. We're going to start off with Mr. Kevin Elak.
All right, thank you, Charles, and thank you, Coach, for bringing this important subject to the spotlight. It is something that's very critical to talk about, and it is something that you know, it is an epidemic that we're seeing during a coronavirus pandemic. So I'm going to try to share my screen here, so give me a second. Can everybody see my screen now? Okay, I'm getting a yes. All right. So again, my name is Kevin Elak. I'm with the I'm the public health manager with the City of Middletown Health Department. Let's see. Okay, so this is a screenshot that I took from Connecticut Magazine just from August 2nd, which the headline reads that the twin epidemics taking a toll in Connecticut as the opioid overdoses rise amid the coronavirus. So we know that you know, everybody knows that with the coronavirus that the epidemic and you know, people being in lockdown and businesses closing, that it's affected all of our lives. And we've seen a rise in other things because of the pandemic, you know, substance abuse and overdoses being one thing, you know, of course, you know, domestic violence, and of course, never mind the economic impact that it's had on the toll that it's had. So we've definitely, a lot of, you know, other things have come about, you know, besides the, you know, coronavirus cases. And part of this article, it talks about the statewide figures for the months from March through May. So basically when the pandemic started in March of 2020, so the data that was available in May shows that deaths from opioid overdoses rose about 21.4%, the difference between the same time in 2019 and this year. So that's quite a significant rise. So I'm going to go over some, I'm going to start with some statewide data, and then I also have some countywide and local and Middletown data to show you as well. So this is from the Department of Public Health that they reported from January till the middle of August 2020. There were 831 confirmed drug overdose deaths and about 223 pending cases. So that's, you know, just over, you know, 1,000, like 1,050, you know, confirmed drug overdose. So those aren't just the opioid, of course, that's other drugs, which can be prescription drugs, even over the counter, other things like that. And then at the same time in 2019, there was about 1,200. So you can see where, you know, this is only until the month of August, and we're already seeing that the numbers are almost surpassing what we've seen in all of 2019. And then of course, the 20% increase in drug overdose deaths by July 2020 compared to the same time period in 2019. Just to give you, show you a couple of charts that were provided by the Department of Public Health, just to give you an overall, you know, view of the trends. Again, the blue bars there being the 2019 and the orange being the 2020. These are the number of drug overdoses by month. And again, these are statewide. So you can see, and just about all of those actually, that the number of deaths are significantly higher, especially during the, again, the beginning of the pandemic, and April was probably the most significant increase there. That's when we were, you know, deep into lockdown, or, you know, staying home at that point. This one I know is probably a little hard to look at, but this is by gender, over mortality rates, again, Connecticut by gender. And you can see, again, looking at the 2019 for male and female, in general, you know, that the males are more likely to die from an overdose than females. And again, the numbers were significantly higher so far in 2020 than 2019. And then as far as, again, mortality rates in Connecticut by race and ethnicity, you can see that non-Hispanic Blacks, again, the rate is higher. You know, definitely in 2020 compared to 2019. And then just one more by age, again, a comparison that you can see the, you know, 35 to 44 age range is the most impacted. Again, moving on, this is now county-wide data. You can see where Middlesex falls compared to the other counties. Again, the rate is higher in 2020 compared to 2019. And then this is just additional data that was provided by the Department of Public Health. So this is for all of Middlesex County. And again, these are total deaths, which include opioid and the non-opioid deaths in Middlesex County. And again, you can see that and again, this is from comparing all of 2019 with January until August 2020. So you can see that we're at already in August, the deaths that matched all of 2019, and the numbers are pretty much the same. But we still have a few months to go, of course, in the year. And then this is specific to Middletown. Again, you can, the total deaths, the same time period as the previous slide, where we've already surpassed the total drug overdose deaths for this year so far than all of 2019. And this one actually breaks it down by opioid and non-opioid deaths. And as you can see, most of them are opioid-related deaths. Moving on, so the state of Connecticut utilizes a dashboard called ODMAP, which actually I think it's on my next slide. I'll go back to that map for a minute. ODMAP is stands for Overdose Detection Mapping. It's a project by the Washington-Baltimore high-intensity drug trafficking area. So they made this program available to jurisdictions throughout the country, and Connecticut is one of those. And the state health department has shared it with local health jurisdictions to be able to view this data. And this helps us to identify actually on a map where the cases are occurring in jurisdictions in real time. And with this, we can set up spike alerts, and those are the ones that I send Charles Mitchell and other agencies in town in real time, that we can identify when there's been a spike, which we identify as 3 or more overdoses within a 24 hours. So we can quickly identify at least where they're occurring, so we can even focus efforts to where they're being, where the overdoses are occurring. Let me just go back. So this is what, I don't have a illustration of what the map looks like for Middletown in here, but just to show you what it looks like. So we're able to, narrow it down to county and even town to look at where the overdoses are happening. You can see with the on the legend over here on this side, it actually tells you if they were fatal, or if naloxone was administered, or how many doses, or if it was administered at all. I will say for Middletown, probably a good 80% of the overdoses occur in the downtown area. Moving on to this is data from ODMAP, and there is a little bit of a discrepancy of what's shown on here versus the slide I showed you from that data was actually right from the office of the chief medical officer. So some of the fatalities and cases probably don't show up in ODMAP, but again, it's quite significant, the difference between, again, this is the countywide data for, again, 2019 versus 2020 during the same time periods from January to August. Quite a significant difference in 2020, what we're seeing so far, compared to all of 2019 as far as the suspected overdoses and the fatalities as well. And then for Middletown specifically, again, it's quite significant in the difference. The fatalities, thankfully, have been not as high so far in Middletown, but certainly many suspected overdoses. I think that's all I have, actually. Let me stop sharing here. So I think we're probably reserving questions to the end, so I will pass it on now to the next speaker.
And that would be Dr. Michael.
Right, can everybody hear me okay? All right, thanks, thanks, Kevin. It's presented some great data, and certainly not surprising. I think it's a little discouraging. We had been making progress in terms of overdose deaths over the last couple of years, and this year obviously is a big setback there. I want to thank everybody at the Chamber of Commerce for inviting me to be part of this panel. It's really a great opportunity. Just as a brief introduction, I'm Dr. Michael Kalinowski. I'm a family physician. This is a topic that's really near and dear to my heart. As many of you know, I grew up in East Haddam, and I've spent most of my life living and working in different areas of Middlesex County. And unfortunately, I've had close friends of mine that have suffered from opioid use disorder, and I've had friends of mine that unfortunately have lost their lives to fatal overdose from opioids. So I think, you know, as we talk to people, that's very common, and all of us have a story that we can share. But it's a very important topic to work on. Clinically, my roles these days are a couple of different things. One, I do some teaching with the Family Medicine Residency Program at Middlesex Health, which is a great experience. And I'm also very involved in community medicine and a number of different initiatives. And one of the groups that I have the pleasure of working with is the Durham Middlefield Local Wellness Coalition. And a few years back, we started kind of rolling up our sleeves and trying to contribute to helping on this topic. And we applied for a federal grant through the Comprehensive Addiction and Recovery Act, which is also known as CARA. And we were very, very fortunate to receive this grant to be able to work on prevention strategies related to opioid addictions and opioid use disorder. So my passion is really upstream, thinking about disease prevention and ways that we can do that effectively. And the focus of the work that I do in this topic is really working with youth and young adults on preventing new addictions. And I think it's really important when we think about the Chamber of Commerce, realizing the students of today are our employees and our leaders of tomorrow. So I think we all have, whether we're parents or grandparents or not, we all have a very vested interest in the long-term health of our children and our students. So it's very important. So I wanted to start a little bit today by presenting some data that I like to share. This is from the National Survey on Drug Use and Health through the SAMHSA organization. And if we think about the data that Kevin was presenting as really the end stage of opioid use disorder with overdose and fatal overdose, I want to just take us back a minute to the very beginning stage of this condition. So if we think about the number of individuals who ultimately will end up addicted to heroin or some other illicit opioid substance, only about 20% of those individuals actually started by injecting or snorting that illicit substance as their first opioid exposure. And what that means is that 80% of those individuals, their initial exposure that set the stage for the addiction was actually exposure to a prescription opioid medication. And that may be something like Percocet or hydrocodone or OxyContin or oxycodone, lots of different names. So 80% of these addictions are starting with prescription medications, and that's really been well documented over the years. And then if you look at those individuals, so that 80% that's starting with a prescription medication, and you try to say, where are they receiving those initial opioid pills? So roughly 20% of those pills were prescribed to the individual by their own doctor. 54% obtained that medication free from a friend or relative. So it was just given to them by someone who had received that prescription from their physician. 15% bought or took that medication from a friend or relative. And only about 5% of those individuals obtained that opioid prescription medication from a quote unquote drug dealer or stranger. So when I first saw this statistic, it was a little bit surprising, and it really shows us, and we know well that overprescribing of opioids by physicians and clinical providers is a problem, and we're working on addressing that. But also sharing medications is a big problem, and not disposing of medications is a problem. So I just wanted to kind of share that information to set the stage. So when we look at the work that we do with our prevention grant, a reasonable strategy for preventing new opioid addictions includes looking at how these medications are prescribed, how they're utilized, how they're disposed of, and whether they're shared or sold. And making a change in this issue involves enacting a cultural shift at each step of this process, looking at a cultural shift in how providers prescribe opioid pain medications, what education they provide, and then in the home, what's being done with those medications after they're not needed any longer. So our efforts have focused on the following approaches. So we work on education of students about the science of addiction and the potential risks of opioids and really understanding what is happening in the brain with the process of addiction. Education of parents about safer pain management strategies for their children. Education of the community at large around safe medication storage and disposal. Education of clinical providers about opioid use disorder, safer prescribing strategies. We hold drug take-back events in our towns. We've been trying to distribute a lot of drug deactivation bags, and actually just have a sample. This is a company, doTERRA. There's a number of different companies that do this, and this is a means to safely dispose of controlled medications in the home and do so in a way that's responsible for the environment. And also promoting efforts in the community to recognize and improve mental health, which we all know is really critical. And there's a high interplay between mental health conditions and addiction. If we think about the COVID-19 pandemic, we all know that this has caused unique challenges. And certainly in the work that we have been doing, there are some specific challenges to the delivery of these services that we've experienced over the last 6 months. So I just wanted to spend a few minutes kind of sharing my perspective and observations on a couple of these issues and obstacles that we have encountered. So if we think about teaching and learning in the school environment, and I'm really lucky that I get to go in and teach health classes at the middle school and high school level in a number of towns, obviously the shift to virtual distance learning has changed that. And all of those efforts got put on hold for time being. And now we're in September and my children and other children are going back to school. Some of that is a in-person model. Sometimes it's a hybrid model, and there's some students who are still distance learning, but outside speakers are not allowed on campuses. So we're having to make a shift. And just like we're doing today, we're shifting away from in-person meetings and shifting to virtual education via Zoom or Google Meets. And as we all know, probably way too well, 6 months into this, there are pros and cons to virtual meetings. So that's a new unique challenge that we're facing. It's also critically important that we all focus on the mental health of our students. And they may not necessarily communicate this to us, but they are experiencing significant stressors during this pandemic. And we've seen an increase in anxiety symptoms, an increase in depression, and certainly an element of social isolation that our children and adolescents are going through. So that's important that we keep in mind. Shifting a little bit to the clinical environment, during the height of the pandemic in the spring, a high percentage of physician visits were conducted via telemedicine. This was both exciting and challenging. And certainly there were types of visits that were very conducive to telemedicine. Certainly some mental health evaluations, mental health follow-ups worked very well. Chronic disease follow-ups that were stable worked very well. But it was very challenging when we were seeing patients that had, you were trying to establish a new diagnosis. You had an uncertain condition that was going on and you were trying to go through an evaluation to make the right diagnosis. Certainly our ability to perform physical examination via a computer screen was very limited to just visual inspection, what folks were telling you, and sometimes even coaching somebody to perform an exam maneuver on themselves and just report back, okay, press in this part of your abdomen. Are you feeling any pain? What does that feel like? So it was, I think, a big learning curve for us to sort out how do we try to do that effectively. And I think that that's a risk factor because lack of clear diagnosis certainly is a risk for improper treatment and improper prescribing. So I think in the clinical venue, we were all challenged to make sure that we were being very, very cautious with our diagnosis and our treatment approaches, especially with undifferentiated pain conditions. No doubt, we saw a large increase in acute anxiety, in acute panic symptoms, and stress reactions in a lot of individuals this spring. And a lot of patient visits were for these conditions. So prescribers really needed to exercise a lot of caution not to overprescribe benzodiazepines, which are a certain class of prescription anxiety medications, not the best option by any means, but that sometimes is prescribed for acute panic or acute anxiety. And we know that benzodiazepines greatly increase the overdose risk. So especially if somebody's taking an opioid pain medication or using an illicit opioid and they add benzodiazepines to the mix, their overdose risk goes way up. So we had to exercise a lot of caution to really try hard not to prescribe these medications. And lastly, if we think about child and adolescent wellness visits, the vast majority of those visits were conducted virtually this spring due to COVID. And those wellness visits are usually a very important opportunity for providers to screen for health issues, including mental health conditions and substance use issues. And in some cases, the virtual aspect of these visits may have interfered with the comfort level of engaging in these sometimes sensitive and private conversations. So there may have been some missed opportunities there for screening. Shifting gears a little bit to the topic of controlled medication disposal, unfortunately, the drug take-back day in April of this year was canceled nationwide. Typically, those occur twice a year. Fortunately, we are on track to be able to hold a drug take-back event in October. So on Saturday, October 24th, there will be nationwide drug take-back events. And through our Wellness Coalition, we'll be hosting drug take-back drop-off sites in Durham and Middlefield. And I suspect a lot of the towns in our community will be holding similar events. Participants are going to need to wear masks and obviously adhere to social distancing, and we'll likely have to get creative with some sort of no-touch drop-off technique. But eliminating these unused medications from our households is really, really important. But interestingly, the absence of a spring event kind of led us to get creative when it comes to medication disposal. And as a coalition, we developed a doTERRA home delivery program this spring and summer. So community members were able to sign up via email to have drug disposal bags and education materials brought directly to their home mailboxes during the height of the pandemic. So once we had a list of people signed up, I would get in my car and I would gear up, masked and gloved, and make the rounds around the community, driving site to site, and personally bringing these supplies to individuals' mailboxes, kind of in a safe, controlled fashion. So I think that this was helpful. Definitely, we had some positive feedback that folks were appreciative of this, and it was actually a really interesting way to get to know a lot of the back roads throughout our town communities. So in an ideal world, right, we would be able to prevent every new case of addiction. And we know that there's no way that that's going to happen. And unfortunately, as we've seen with Kevin's presentation, we know that overdose has increased over the course of the pandemic, and indeed long-term addictions are likely to have increased. So there's so many critical aspects of this between treatment, addressing stigma, looking at recovery. And at this point, I'd like to turn the discussion over to Dr. Gayani for the next stage of the discussion. Thank you.
All right, thank you, everybody. Let me share my screen. Okay, can everyone see that?
Yes.
Okay, thank you. So thank you, Dr. Kalinowski. My name is Hamilton Gayani. I'm an addiction psychiatrist. I work for Middlesex Hospital. I do inpatient, outpatient, and intensive outpatient work. We have 2 IOP programs that are focused on treating people with substance use disorders. One is a dual diagnosis program, and our newest one in the evening is for people who are primarily struggling with substance use disorders. So we're really excited about that. And I just wanted to talk a little bit about stigma in substance use disorders, because I just don't think it's talked about enough. And it's really a major reason that a lot of people do not engage in treatment. So just in terms of the definition, so the sociologists define stigma as both a discrediting individual characteristic and also a social process which involves labeling, stereotyping, and status loss, and is often exacerbated when there's a power dynamic. if you look at some of these big surveys, national surveys about stigma and addiction, you see that persistent barriers related to stigma is a major reason that people do not engage in treatment. And in fact, only about a third of individuals with substance use disorders even seek treatment. And that includes mutual aid groups like AA and NA and other 12-step groups, Smart Recovery, et cetera. And another large survey, 23% of people who did not present for treatment said that they were worried about stigma. They were worried about their jobs, what people would think at work, what the neighbors and the community would think. So we really have an opportunity to, just all of us, to think about what ways we can improve that so that people feel more comfortable engaging in treatment. The World Health, this is a global problem. The World Health Organization looked at the most stigmatized conditions, which in 18 of the most stigmatized conditions globally, and found that drug addiction or substance use disorder was the most stigmatized. And that includes criminal history, HIV, people who are housing insecure, and alcohol use disorder was fourth most stigmatized globally. And stigma really comes from everywhere. It can come from society. There's self-stigma. People internalize the things that the ideas they have about people with substance use disorders. Community support groups, some of them have some policies that I would argue are still rooted in some stigma. Healthcare professionals have been shown via a lot of research that some of them do have stigma and hold negative ideas about people with substance use disorders. Other systems and even rehabilitation centers, some of them have policies that have yet to really advance to what we know about substance use disorders now. And it can come even close. It can come from a spouse, it can come from a partner or a family member as well. In society, stigma towards substance use disorders has remained high, even though everybody knows more about it and there seems to be more public support in general for treatment for substance use disorders. But at least as of some research in 2014 and 2016, it's still quite high. And it can lead to decreased public support for funding of treatment programs and increased support for more punitive policies, arresting people who are quote unquote doctor shopping or something, even though that's really a behavior associated with the illness. If we look at some of the public attitudes about mental illness and substance use disorders over time, there's still plenty of stigma with mental illness as well. In '96, the authors looked at if people were willing to work closely with someone with schizophrenia, depression, or alcohol use disorder, and 72% of respondents did not want to work closely with someone with alcohol use disorder, and almost half for mental health conditions. And this really didn't change all the way through 2006. It was still 79 and almost half for substance use disorders. And then violence, the idea that people with mental illness or substance use disorders are more violent has remained persistently high as well. And more recently in 2013, we were still showing some of the same stigma, but this is more so with drug addiction, was the survey here. And then some self-stigma that I briefly mentioned earlier. Just some observations from anecdotally from working with patients is that the patients may have an idea about what somebody with an alcohol use disorder looks like, and they don't want to be associated with that, even if they do have an alcohol use disorder. So they've internalized that and are also perpetuating it in a way that keeps them from engaging. And guilt and shame are often really common and not really explored enough, and those are reasons that people don't want to necessarily disclose all the details of what's going on with them, and become a hindrance to their treatment goals, reuniting with families, et cetera. So those are things that we really should look out for, and the best way to combat that is empathy and compassion. NA is an excellent organization. It saved countless lives, done great work with many people in the community, but they do still have some policies that are questionable, especially considering buprenorphine and methadone as replacement rather than treatment. And we know, bar none, that these medications save lives. So I'm often combating patients who come with this idea that they need to get off these life-saving medications because they don't feel like they're really in recovery if they're on them. In healthcare and behavioral health, there's been a number of research studies that have shown that it's pervasive, and a lot of providers have these negative ideas about people with substance use disorders, that they're irresponsible, more aggressive, or dangerous or untrustworthy. Other sources, some treatment centers, many, this is changing overall, but many of the residential treatment centers in the United States still don't really offer or encourage medications for opioid use disorder. Some of them are very 12-step focused, which is great, but we also have to understand that harm reduction is important, right? And so some people's goal may not completely be abstinence, and we need to find a way to treat them as well. Family members sometimes tell people to get off their medications, or the just say no approach, why can't you stop, like it's a willpower issue. So one of the most effective ways we as a community can affect this is just to think about our language, and also always be non-judgmental and provide empathy and compassion. Language has a long history of perpetuating stigma. In the past, we've called people with mental illness lunatics, and HIV was gay-related immune deficiency. And now we have all these pejorative terms like junkies, crackhead, drunk, alcoholic. And I would argue, and the literature would argue, even the term abuse can be stigmatizing. So rather than say substance abuser, I would recommend we use first-person language that clinically describes what's happening, right? A person with a substance use disorder. We don't call people with eating disorders food abusers, right? So the idea that is, and it has been shown in some of the research, that using that term abuse really conveys the idea that the person is more of a perpetrator doing some willful misconduct. But using a substance use disorder, this shows that we're treating somebody, or we're working with somebody who has an illness. And that's characterized by loss of control or impaired control over their substance use behavior. Other terms that we can be mindful of is, rather than using clean and negative, clean is often used to talk about sobriety. It's also used to talk about a negative urine, but we should describe sobriety as abstinent or in recovery, rather than clean and dirty, which can perpetuate some stigmatizing ideas about somebody who is in active addiction being dirty. And just as a review of some of the things that we've talked about, and that ways that we as a community it really does require community approaches to use the non-judgmental language and tone. If we encounter judgmental or non-preferred terms, educate, right? Educate your peers and your colleagues. Understand that the person may not be comfortable meeting with an addiction professional. So any support or encouragement from any peer or professional can have an impact. Recognize that people may not want to confide in us if they feel we will judge them. And for people who work with patients with substance use disorder specifically, think about the diagnosis. There's still ability to diagnose with those older terms, abuser, detailed substance history, showing that we're really interested in all of their health problems, and asking about guilt, shame, and trauma. Thank you very much. I'll turn it over to the next presenter.
I was asking if everyone could see my slides. Of course, I was muted. Are they on there, Charles?
Yes, they are.
Excellent. Thank you, Dr. Gianni. That was an excellent presentation. And I think one of the last points that you were making is that some of the greatest stigma and discrimination that I see can actually come from the people who are suffering from the substance use disorder, and that those feelings of guilt and embarrassment and shame really have to be addressed in order to properly to get people into treatment and to provide the right sort of supports. I want to thank the Chamber of Commerce and Charles for putting this together. This is really an important topic. Again, I'm Craig Allen. I'm the medical director at Rushford. I'm a child and adolescent psychiatrist and an addiction medicine doctor. Rushford provides substance use and co-occurring services in Central Connecticut, and one of our main locations is in Middletown, down the street from Middlesex Hospital, over on the campus, near the campus of CVH. Throughout this pandemic, I'm proud to say that Rushford was able to keep the doors open at our withdrawal management or detox program in Middletown. And the number of patients we were able to treat was the same as similar to last year, which is strikingly different from most of the other like programs in the state. At Rushford, we have outpatient services, intensive outpatient services, partial hospital services, and then withdrawal management, residential, intermediate care. So the full continuum of services, all of the so-called ASAM levels of care are provided. What I want to talk about today, well, first starting with the definition of addiction, but I want to talk about those treatments that Dr. Gianni and Dr. Kalinowski touched upon. First off, the definition of addiction: it's treatable. It's a chronic medical disease. It involves complex interactions, genetics, environment, different brain circuitry, and someone's personal life experiences. People with addictions, they use substances and engage in substance-related behaviors. It becomes compulsive, and they continue to engage in these behaviors despite the harms that are caused to themselves and those around them. Prevention efforts and treatment approaches, and this is important, prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases like COPD or diabetes or hypertension. And so what Dr. Gianni was talking about, people avoiding treatment, it's really a missed opportunity and a tragedy when people don't seek treatment because there is effective treatment available. Opioids bind to receptors in the brain. So any kind of opioid you take, whether it is, as Dr. Kalinowski was talking about, a medication for pain, an opioid pain medication being prescribed by your doctor, or whether it is an illicit substance that someone is using to get high, the same receptors get bound in the brain. And that's one of the reasons that it's so potentially dangerous. So this is the pain pathway. And when opioids bind in the pain pathway and you're trying to treat pain, that's great. You get analgesia, you get pain relief. The reward pathway, which is on this little picture, a cartoon up on the left, it's that orange area. That's the part of the brain that when there's the binding takes place with the opioids, dopamine gets released and there's a feeling of being high, or euphoria. And this is the path that can lead to addiction. And then down in the brain stem, down in this area is the respiratory drive center. And unfortunately, opioids bind there as well and slow down the respiratory drive. When this system becomes overwhelmed, that's what leads to overdose. When we talk about opioid overdose deaths, that's why death occurs. The respiratory center is overwhelmed. It shuts down essentially, and the person dies. And this can occur when there's a change in the strength or potency of an opioid someone's taking, or if someone returns to using and hasn't used for a while. What happens when you use again and again and again, and I'll get to a slide in a second that shows that, is you develop tolerance, meaning you can use more and more of the same substance, trying to get that same effect. When you stop using for a period of time, that could even be as long as, if someone is incarcerated or someone stops using for 3 or 4 days and they go back to using, their system loses this tolerance, and your respiratory drive center can be overwhelmed. This slide here shows someone who may be using an addictive substance. In this case, we're talking about opioids. So someone who's using recreationally, trying to get high. And this is the same pattern that would take place for alcohol or take place for marijuana. In the white area is your normal affect, how you normally feel. When you use this substance, dopamine gets released in the brain and you feel euphoria, you feel high, it wears off, you go back to feeling normal. And, someone who is having drinks on the weekends, 2 or 3 drinks on the weekends, this might be the pattern. As this is acute use, as you continue to use, you develop that tolerance I was talking about, as well as physical dependence. So your body and your brain get used to having this sedating substance around, and your body and your brain try to reach a steady state, like a teeter-totter or homeostasis. And as you're using more and more of the same substance and not getting the same effect, and the physical dependence is developing, when you aren't using, you actually start feeling worse than you had felt at baseline. And the physical dependence can lead to withdrawal symptoms and really, really bad flu-like symptoms, stomach upset, diarrhea, and people that have substance use disorder go through opioid withdrawal talk about the worst flu you could ever imagine times 5. The difference in this situation is that you know exactly how to cure those symptoms. Go back to using. And so that's the challenge. Someone who's trying to stop has psychological and physical reasons that compel them to continue using. The idea around using medications, FDA-approved medications, medication-assisted therapy, is to get back to this baseline area. The benefits of using medications, this is a simple slide. People who use medication to treat opioid use disorder, people that don't use medication to try to address opioid use disorder, and the general population, and these are death rates. People that use medication have a significantly increased chance of living. So using one of the FDA-approved medication-assisted treatment strategies decreases your risk of opioid overdose death somewhere between 50 and some studies have said close to 80%. So this is first-line treatment for opioid use disorder, is using one of the 3 FDA-approved medications, and I'm going to go through those medications, talk a little bit about the differences and where you would go to get those medications and some of the concerns. The oldest medication treating opioid use disorder is methadone. And methadone acts similarly. It's a full agonist, so fully binds this receptor in the brain, just like the addictive drugs. The difference being this is prescribed. You take it on a dosage regimen, and it's much longer acting. And so you stop having an urge to use heroin or fentanyl or other opioids when you take this medication. You can only get this medication for opioid use disorder at a methadone dispensary, so a federally licensed program to get dosed with methadone, and you're dosed. And when you first start, you're dosed 6 or 7 days a week. You go in the morning, usually it's early in the morning, you get your medication. There can be benefits to this. It helps you structure your life. It helps you to stay organized, and it gives the staff a chance to see how you're doing. But there are certainly drawbacks. Some of the discrimination and stigma that Dr. Gaina was talking about can go along with methadone dispensaries, as well as the impact it has on your life and your ability to do other things, take care of your family, go to work. You've always got to be you go on a vacation. It increases challenges. So buprenorphine-based medications are what are called partial agonist medications. They block this receptor. They slightly activate it. The withdrawal symptoms I was talking about will go away when you use this medication. But if you try to use another opioid, it will block it. It won't allow that other opioid to attach to the receptor. There's a problem, though, because this binds so closely. If you use it too soon after you've used the illicit opioid, you can have what's called precipitated withdrawal and go into withdrawal right away. Benefits of this medication, it's not fully activating. It is not, it doesn't have the same reinforcing or high effects that methadone could initially have. It can precipitate withdrawal, but you can get this medication at your doctor's office or at the clinic, get a prescription and go fill it. You don't have to line up necessarily every day to get dosed with that medication. And then the third is a blocker. It doesn't activate the receptor at all, but it totally blocks the receptor. The benefits are you do not develop a dependence on this medication. Some of the drawbacks can be you have to wait 7 to 10 days to use it, or you will precipitate a withdrawal. And that is a huge challenge for someone that can't stop using even for a day, to try to get them to the point where they can get onto this medication. This comes in an injection monthly and also an oral form, but really the oral form is a challenge. People forget to take it or choose not to take it. The injection is the gold standard. This also can be gotten at a doctor's office. This shows some difference in the activation of the receptor. You see the full agonist methadone fully activates the receptor, but also on the impact on the respiratory system. So methadone can have a definite impact on the respiratory system, much less so buprenorphine. The name brand for the buprenorphine medication people are familiar with is Suboxone, and then naloxone or naltrexone, the injectable, the name brand is Vivitrol, no impact on respiratory drive. Naloxone is similar to naltrexone, but fast acting. This is what saves lives. This is what should be in everybody's briefcase. This is what should be at all the gyms and in all the schools. It's a safe medication that can reverse an opioid overdose, keep people alive so that they can get into treatment and get into recovery. These are some of the things that increase your risk of having an overdose. Really, this medication should be prescribed and discussed with anyone getting a prescription for an opioid analgesic. And this is a medication that our first responders are carrying. And we try to flood the community with it coming out of Rushford programs. That's the end of my presentation today. Hopefully we'll have some questions later. We're going to move on to Margaret O'Hagan Lynch.
Okay, there I am. Thank you, Dr. Allen. That was a great presentation. So what I'm going to do is, well, first I will introduce myself. I'm Margaret O'Hagan Lynch, and I am the Division Director for Addiction Services at Connecticut Valley Hospital. So I oversee all of the inpatient addiction beds for the state of Connecticut. As Dr. Allen started to allude initially in his presentation, he talked about the various types of programs that Rushford have and the continuum of care. And so I'm going to talk a little bit about what that really looks like. And so there are various types of treatment options for people, one of which is inpatient, but that's the highest level of care. And so many people often think when somebody needs treatment, they think, oh, I have to go inpatient, or, oh, this person should go inpatient. And there's a whole myriad of continuum of services that people can access other than just inpatient. And we generally go by the rule of thumb that you want to go to the least restrictive level of care. So all of that depends on what is happening with you in the moment, what your symptoms are, what your support systems are. But generally speaking, often the first route into the treatment system would be outpatient. So you can try, there's outpatient individual sessions, there are group sessions. You can try that on a usually a weekly basis and see how you do. You can get some supports in place and you can still work. Sometimes if that's not enough for people, then the next level would be perhaps an intensive outpatient. So it's more time in outpatient treatment than just your regular weekly session. But usually you meet with people for about three days a week, up to 3 hours a day. That usually is comprised of various groups with Some of it may be an individual session, but often it's group treatment. If that still is not enough for somebody to maintain their sobriety, then we have partial hospital programs, which is about the most intense outpatient treatment that you can get. So it's kind of a hybrid of inpatient and outpatient. You're living at home, but you're going to treatment for about 20 hours a week. So often you'll see 5 days a week, up to 4 hours a day. And this obviously gives people the ability to continue to work, which is often a benefit for people. Sometimes people will say, well, I can't go to treatment because I have to work. So this is a nice option for people who feel like they still have to work or they don't get time off from work to go to treatment. If people, that is really a very intensive level of care. So if people are still not able to maintain their abstinence in a partial hospital program, the next option for people at that point might be inpatient. So normally inpatient programs are somewhere around 28 days. You go, you stay, or it can be 14 to 28, depending on the program. But you go and you stay there. The benefit of inpatient is you're able to leave your stressors outside the door. You're able to just connect with the other people in the program. You have very intensive group therapy. You have individual therapy. You normally see a psychiatrist, perhaps a psychologist. Here at Connecticut Valley Hospital, we're very fortunate. We have many disciplines. We have psychiatrists and psychologists and medical physicians and occupational therapists and dietitians and social workers and counselors and rehab therapists. So we really have the entire multidisciplinary level of care to offer people treatment services. And then after that, we have the disposition back into the community, which can be, oddly enough, an entire kind of titrating back down again in those levels of care. So you would go from inpatient maybe back to partial hospital or IOP. You would want to take a look at what the environment is like for people. What type of situation do they have to live in? Ideally, if people are going home, it's a stable environment. Hopefully not other people using in their home environment. And if that's not the case, then there are other types of programs they can go to from an inpatient, which might be a residential program. So they would go and perhaps live in another program where they're not inpatient. They can still go out. Often people will work in residential programs, and they might last anywhere from 3 to 6 months. And then there's also another option for living, which is sober houses. And in a sober house, there's other people that have the same mission. People are trying to stay abstinent. And sometimes there are house meetings, but at the same time, people are encouraged to go and work, but they have a supportive environment to go back home to. And at the same time, when they're living in sober houses or they're at home, one of the things that is always recommended is people try to develop a sober support network, right? Because we certainly know that social support actually plays a very significant role in a person's recovery. And there are multiple pathways to recovery. I think as you heard in a couple of the presentations, there was a reference to some 12-step meetings, which are probably the most well-known, things like Alcoholics Anonymous or Narcotics Anonymous, which are based on the 12 steps of initially of AA. And basically, they are non-sectarian groups. Sometimes though, people are off-put by them because there is a spiritual overtone. And sometimes people just can't get past that. And they say, well, I'll go, but I just can't, it doesn't work for me. And there are other actual secular groups that people can go to that have no reference at all to any type of spirituality or religious organization or anything like that. And one of them is Smart Recovery. And that stands for Self-Management and Recovery Training, which is really more based on kind of a science approach, and it empowers people to assume responsibility for their own recovery. There's Women for Sobriety, which is another support group, and that the purpose of that is to help women find their individual path to recovery through their own self-discovery. So they use the support of the other women to be able to do that. There's Life Ring, which is something that we don't hear a lot about in the East, but Life Ring is actually believes that people do have the power to overcome their addiction. So that's a little bit different, because in the 12-step program, though, the first step is, I admit that I am powerless over my addiction. And so what Life Ring is saying is that people do have the ability to overcome their addiction, and that they are the best person to design their own recovery system. Again, it's with support of other people, and they talk about the path that they'll take to do that. There is another program, which is actually kind of the opposite of the secular ones, which is called Celebrate Recovery. And this is actually a Christ-centered program with their foundation in 12 steps, but also with scriptures. And they also rely heavily on the 8 Beatitudes. So somebody who does have a very strong religious or spiritual belief might actually benefit from Celebrate Recovery. They may feel more comfortable. Perhaps that's more part of their culture. So that's an option for them. There's another program called Refuge Recovery, which is more of a mindfulness-based addiction recovery community. And they practice the Buddhist philosophy. And then there's also another one called Wellbriety, which is actually based on the 12-step fellowship, but it's rooted in Native American traditions. There's another, Phoenix Multisport was started out in the West, and this was started by somebody who was in recovery. I ironically became sober in the Boston area and was out West, and none of these other support systems really worked for him. And what he decided to, he was very athletic, and he really liked the outdoors. He was in Colorado, and he decided to start a gym specifically for people in recovery. And they do a lot of things inside in terms of weights and things like that. But then they also do a lot of rock climbing together, and they go hiking, and they go into the mountains. And it's all for people in recovery. So you have your support system in place, and you're doing all of those athletic things that people really, really like, and help their endorphins at that point. And this actually, there's this fellow then ended up getting money for, there was a match in the Boston area, and he raised like $1.5 million in like a ridiculous amount of time, like 5 days or something like that, because they had a matching grant for another $1.5 million. And then they bought an 11,000 square foot kind of factory in the Boston area. And now they also have Phoenix Sports in Boston, and it's all free for people in recovery. So they can go, they can utilize the gym, they do all kinds of activities. So what you can see is that there's a myriad of opportunities for people to develop sober support systems. And people are different. And so you may have somebody that you're talking to, you know, perhaps it's a neighbor, your family member, and they say, you know what, I tried that program, it doesn't work for me. So I think it's really important to know, though, that support groups are not limited. There's all kinds of different types of support groups that, depending on a person's culture or their beliefs, or their likes or dislikes, they should probably be able to find something that they will able to be connected to. Ironically, I think we can all probably list a whole lot of negatives that came out of this pandemic. But one of the positives is that a lot of these programs that I just talked about, these support groups, often were in person. And because of the pandemic, it forced everybody like us right now to do Zoom meetings. And so now there's really more access for people to support groups than there was in the past. So the programs that are often based out west, and maybe we didn't have it here in the east as much access to, we now have access to. And vice versa, things that are happening here that maybe in the middle of the country or out west they didn't have access to, now people do. And so that, I think, is a good thing. And I think it's important that we embrace that and that we really try to get that word out, because people may not be aware of that. There's a lot of information on the SAMHSA website, and especially around the medication-assisted treatment that Dr. Allen talked about. You can certainly go to the National Council on Alcohol and Drug Dependence, and you can, so NCADD, that's it. But all you have to do is put that into Google, and you will actually be able to get a listing of all of the different support groups that I just talked about. So I think that probably ends my my part, and if people have questions, then we could take it in the question piece. So I'll give it back to you, Charles.
Thank you. And now I'll turn it back over to Johanna.
All right, fantastic job and such important information. Thank you so much. Before we go into the question and answer piece, I do briefly want to introduce Catherine Reese, who is with Middlesex Health, and she wants to discuss a very important initiative led by Reverend Anderson titled Middletown Recovery Together, How We Can Help program. So Catherine, if you wouldn't mind taking a few minutes to share with us about this very important program in our community. We may have a delay in that. So we'll go to the question and answer until Catherine is ready. So there was quite a few questions that were asked, and some were answered, but I will ask so the majority of people can hear this. Laura A. asked, is there a certain age range in Middlesex County that the most opiate overdoses and fatalities? I am a senior undergraduate in the rehabilitation service major at the University of Maine at Farmington, but I am from Connecticut. What can I do to get involved during this time to educate others on this topic? Kevin, if you wouldn't mind, I know you answered it via the chat, but for everybody else that's on board, would you mind answering that question?
Yeah, certainly. So I didn't include that information, for the sake of the time allotted. I could have provided a lot more, detailed information, but I did while the chats were going on, I did pull that information up. So for just looking back the past 120 days in Middlesex County for all suspected overdose cases, not fatalities. In general, between the 25 to 39 age range is where we see most of our suspected overdoses.
All right, thank you for sharing. Okay, Catherine is now joined us, so We will go over to Catherine.
Hi there, Johanna. Can everyone hear me?
You might want to speak a little louder, Catherine.
Can you hear me?
Yes.
Okay, perfect. So sorry about that. Thank you so much for giving me a couple moments to review the How Can We Help program. And I am hearing an echo. Is my audio okay?
No, you're going in and out. I don't know if you're on your car or,
I'm on the landline.
Yeah, you are going in and out a little bit, Catherine.
Is it better now?
Why don't we move to more questions at this point, because it's not coming across
Okay.
out, okay, at this point.
Catherine, maybe try another phone and come back to us. All right. Another question was from Lisa Gray. For people on long-term MAT, what are their success rates for recovery once they stop the medication? Dr. Allen, would you mind answering that again?
Sure. What did I say last time?
Do you want me to read it for you?
I said that's really something we're trying to figure out. We don't know for sure. What we do know is that people who are on these medications are at less risk of returning to use or relapsing, and are at less risk of overdosing, and are at less risk of dying. When can someone come off? Who can come off? Who does best? Who's the one we'd be most concerned about? We don't have all of that data yet. In general, with substance use disorders, and most of this data comes from alcohol use disorder, after 1 year, your risk of 1 year of sobriety, your risk of returning to use is just under 50%, or right around 50%. At 5 years, it drops closer to the range of everybody else out there, around 15% risk of returning to use. Does that apply to opioids? Maybe, maybe not. I don't know if Dr. Guiana has any other data on that.
I don't. We're still trying to figure out the long-term rates, as you mentioned, Dr. Allen. We do know that certainly stopping the opioid medications too early leads to almost a 90% rate of recurrence to use. Right. So generally, the advice is still to take the medication as long as there's a benefit, right? And at least a couple of years is what I recommend.
Yeah, and as Dr. Guiana says, people that do not use the medication are at probably greater than 90% risk of returning to use. So if you go through withdrawal management, you come to the detox program, and you're going to make it without medications, you're taking on a high risk of returning to use. And we know that returning to use with fentanyl and fentanyl analogs, these really potent substances out there, means potentially dying of an overdose.
Okay. Teresa Opalats has asked, can CVH tell us again the site for all the treatment centers? Is there a call line for employers if they think there's an issue with an employee? Margaret, I think you're on mute.
Thank you. At Connecticut Valley Hospital, there is a call-in line, which of course I don't have the number off the top of my head, but I can get that while somebody else is speaking. And yes, employers can certainly call if they have a question about an employee. Actually, I can give you my telephone number. That might be the best if you're an employer who has a question. And I'm happy to give that number. And my number is 860-262-6503. And depending on what your situation is, I can refer you to the best person, or I can give the information to the employee, either have the employee call or what have you. But I'm happy to actually speak on the case-by-case basis of what the situation is.
Okay, great. I did have an email come in with a question. How can doctors be more diligent in screening potential users of opioids as a result of surgery?
There are a number of different screening tools available. This is Dr. Allen. There are a number of different screening tools available for risk of developing a opioid use disorder prior to prescribing. There are also tools available that go along the lines of this term SBIRT, screening, brief intervention, referral to treatment. So there's a lot of evidence-based screens. Some of them are very simple to do. I see Dr. Kalinowski nodding his head. He could probably tell us more about SBIRT stuff.
Yeah, thanks, Greg. Yeah, I mean, I think a lot of it is, you know, kind of making this the standard of care and building this into all of our practices. I agree. There's a number of different screening tools that can be applied to different clinical situations. If you're a clinical provider in the community, one of the tools that we've actually put together is a online opioid use disorder toolkit, which I'm happy to share if anybody is interested. And we've got a number of screening tools built into this and listed. And I think, again, it really just comes down to kind of making this the standard of care, where we build these questions and we build these simple screens into our regular practice.
Dr. Kalinowski, can you put that in the chat box? Is that something that's a link, the toolbox?
Yeah, I can try to, but I'm not technologically savvy, so no promises. I'll see what I can do.
If not, we can share it via email after. And Catherine did send her apologies. She was having some technical difficulties, but we will absolutely be sending you guys an email after with some emails from our presenters, and also with the How We Can Help program from Catherine Reese. So please watch your email for that. We have a couple statements actually, so let me just scroll right down. Hello, everybody. Thank you so much for being here today and all your efforts in combating the opioid epidemic. I can't thank you enough. This topic is passionate for me as a member of the chamber and a man 6 years in recovery and now a multi-business owner. What would be the best service can I offer to our community to help your efforts in our county?
I think I would say yes, just education that there is treatment available, and to speak to that stigma issue that addiction is an illness and nobody needs to be ashamed about it, and it's just like any other illness that you have, and we're all used to kind of just going to your doctor or going to the hospital and saying, hey, this is going on with me. And I think to open up that conversation, which is definitely getting better. I think there's no doubt that people are freer now to share when there's addiction going on in the family, or but to encourage people to go and have a talk with their doctor, because it's an illness, and that's I think an important piece.
Also, the chamber has been very active in the substance abuse area since the 90s. And we feel very strong that it is an illness, and we have to really try to react to that illness as an illness, basically offer the support. So I would urge you to contact Harry Burr, who's done a great job working with the chamber, along with Tony Salvatore, really the leads of McSack, a guy like a Jay Polk, and get involved with us to go forward with this. This is very important for the business community, something we can't duck. We have to be out there in support of it. I thought the presentations today were excellent by all of you, and I really appreciate it. I can guarantee you we're not going to stop on this. Charles will mention we plan on having another workshop before the holidays. It's kind of a tough time for a lot of people. So again, whoever that was from, please get back to either myself, Tony, or Harry Burr, and we'll get you involved with us.
Right, and there was a couple questions. This has been recorded. It will be located on our middlesexchamber.com website. We will send you a link to that as well once we have that downloaded. So I'm going to turn this over to Larry for some closing remarks.
Okay, just again, Kevin Elak, thank you very, very much, Kevin, for reaching out to us and to move forward with this program. Our panelists, great job by all of you. I really appreciate your commitment to this. This is so important. As I said before, we will win this battle just by staying together, getting the message out, working together, giving people the opportunity to get to work, which is Charles is doing through our rep program. He does a fantastic job. And keep your ideas coming to us. Get to Charles with any ideas. I know Charles is looking to get people into employment. So anybody would have that opportunity, get a hold of him. He's a great individual. It means so much to each and every one of us here in the chamber. He's gone through both corrections, addiction, all of that. He knows what he's doing, and we'll continue to move forward. So again, thanks everyone. Stay tuned to another workshop that Charles will be putting forward before the holidays. And again, to our panelists, a huge, huge thanks. Sun always shines in Middlesex County. Have a great day, everybody.
Thank you.